We have a little paucity of time because we got the hall a little late, so I'll try to finish off my presentation as soon as possible so that Professor Atul gets a little time to.
No, I'll need about 5 7 minutes.
Okay, sir. So I'm talking on, and thank you for this opportunity. I've been associated with this course since we started it. I'll be talking on symptomatic vitreomacular traction, watchful waiting surgery with Ocriplasmin. This is a study which actually changed the way we classify vitreomacular traction from 2013. This basically an OCT-based classification. Basically an OCT-based classification and actually defined the terminologies like what is vitreomacular adhesion. So you can see here there is an incomplete PVD. The vitreous is still attached, cortical vitreous is still attached at the macular area. But there is no change in the contour of the fovea. There are no cysts, there is no wrinkling on the foveal surface. That means there are no physical findings which suggest that there is any change on the foveal structure. So this is known as a vitreomacular adhesion. When this vitreomacular adhesion becomes symptomatic, patient having metamorphopsia or has other symptoms, or you find OCT findings of a changed contour or cystic changes, then you call it a vitreomacular traction. And both these cases, it can either be focal or it can be broad depending on the area of attachment. So you have a symptomatic vitreomacular attachment, which is called VMT, or it can be just called a vitreomacular traction, and this is an OCT-based diagnosis. Then we come to the macular hole, which comes as part of the same classification. You have a full thickness macular hole, which is again classified based upon the size, either small, medium, or large. Or you can have a lamellar hole where you have photoreceptor layer maintained, and then you have a macular pseudo hole. Now, what is the management of vitreomacular traction? It can be either observation, that is when patient is not symptomatic, the vision is better than 6/12, 6/9. We may not intervene, or you have pneumatic vitreolysis, intravitreal injections of substances which can cause vitreolysis like Ocriplasmin or luminate, and a pars plana vitrectomy. So there are various publications. I'll rapidly run through it. You can either observe these patients, as this was reported then in patients, 106 eyes of 81 patients who were followed up for a period of 23 months. 32% had a spontaneous release and 4.7% needed pars plana vitrectomy. Now, natural history of cystoid macular edema, a complete posterior vitreous detachment occurred spontaneously in about 53% of these patients with tractional cystoid macular edema. It basically shows that if you intervene, you're just altering the natural history, and naturally also some of these tractions may actually resolve. This technique actually is extremely good, where we inject gas in the eye, which basically causes accentuate liquefaction during the gas expansion phase, and the cortical vitreous collapse occurs during the absorption phase. This leads to a PVD formation, and this helps in releasing the vitreomacular traction. There are numerous publications now. I'll just have picked up a few of them. So this was in the AIOC of 15 eyes of idiopathic vitreomacular traction, which showed that predictors of treatment in these cases when the area of adhesion is less than 750 micron, indicating that if you have a focal VMT, it is likely to respond better to vitreolysis by a gas injection versus if you have a broad vitreomacular traction. When the maximal foveal thickness was less than 500 microns, the success rate was higher with a low vitreous face reflectivity. So if you look at the OCT, measure the area of the vitreomacular traction, also measure the reflectivity of the vitreoretinal interface, you will be able to predict whether this patient is going to respond to a pneumatic vitreolysis. Then came up pharmacological vitreolysis. This is the Mivitrust trial, which basically was done in the US and Europe, and it looked at in 650 to randomized patients where Ocriplasmin was used, and 188 were placebo. So these patients, there was 14% had a 3-line improvement, 70% resolved in 7 days, and 100% in 28 days of the patient where the vitreomacular traction was released. In about 28% patients, the vitreomacular traction got released, and about 8% of them placebo it got released. So eventually the effective was 20%. In the macular hole subset, 58% of the macular hole, which were less than 250 microns, they were closed into 28 days. And the most important thing was these patients, the most commonest problem which they had was floaters, they had eye pain, and then they had visual disturbances, which had come up later, where there was a effect on the ellipsoid zone, accumulation of subretinal fluid following Ocriplasmin injection. Then came up the OASIS study, which was an Ocriplasmin treatment for symptomatic vitreomacular traction, including the macular hole, which was a phase 3B trial, where they showed that vitreomacular adhesion or traction resolved in 28 days in about 41.7% cases, and it was in placebo, the effect was in about 6% cases. So the effective overall is between 28 to 33% cases where Ocriplasmin is effective. There have been numerous studies which have shown that there are visual problems related to Ocriplasmin, and since that drug is very expensive, most of us have not, I have personally not used it, and I don't think many people have used it in this country, because the drug costs almost $4,000, and it's better in these cases for us to do a vitrectomy rather than inject Ocriplasmin. Kupperman came up with this another agent, which is Luminate, which is a little better than Ocriplasmin. So this was a prospective double-masked placebo-controlled phase 2 clinical trial of 106 patients. 65% of the patients treated with 3.2 milligram of Luminate achieved a release of vitreomacular traction. So in the end, let me just show you a few principles. If you have, that is how you calculate the force, that is stress that is exerted on the fovea. Depending on the area of attachment, you can calculate the stress. So if you have a focal vitreomacular traction, the stress is the maximum. So if you have a broad attachment with a good visual acuity, you'll observe. If you have an attachment like this, you could actually operate by cutting off here and settling this. Or you could wait, because the vision in these patients may be better. But if you have an attachment like this, you will operate. Again, if you have a vitreofoveal traction like this with a macular hole, you will go ahead and operate. A situation like this, you will definitely go ahead and operate, and this is just an example. We went and operated. The patient did pretty well. These are some of the old slides. The focal attachment like this, you will definitely go ahead and operate, and these patients do pretty well. Again, a similar patient who you have to treat these patients with PRP, anti-VEGF, and a surgical intervention, and these patients do well. So this, in summary, the strategies for management of VMA are PVD induction and gradual hyaloid separation. If the fovea is dentate, trim the hyaloid membrane around the fovea. If ERM is tightly adherent, you will use a Brilliant Glue assisted ILM peel. Intraop OCT may be further helping. Thank you very much.